Hello to everybody who's attending our webinar today, and welcome. My name is Jacky Davis. I am Chair of Healthcare Professionals for Assisted Dying and on the board of Dignity in Dying. And we hope that this session today is going to be helpful to anyone who's interested in the legislation that's proposed at the moment. A few bits of housekeeping first. We're very keen for you to be able to ask questions. If you could submit them on the Q&A function, and if there's a particular panelist you want to direct it to, if you could say that. The chat function is off because it tends to be very distracting during these meetings. If we don't address your question, we will try and email you a reply. So please feel free to ask. And the webinar is being recorded. Your cameras are off and your personal details won't be publicly available, obviously. We have clinicians here today, we have parliamentarians here today, and I hope everybody will find this a positive, useful session that will answer the many questions that remain for people in this country around assisted dying. As a clinician, I'm very interested in how laws are translated into practice by doctors for their patients in the best possible way. And I think it's really important to acknowledge that assisted dying has been going on abroad for over 25 years in Oregon, and now in many jurisdictions. Over 300 million people in the world have access to assisted dying. Many more places are coming online. We need to learn from people who are doing this abroad already. We don't have to reinvent the wheel. And that's why it's really helpful to have 4 people from Australia today who are involved in assisted dying, because if we get the legislation, it will look very like the Australian legislation. I think we can learn a great deal from talking to people over there. So welcome to our panelists. Of course, it's evening for you over there, and I know you're very busy people. We really appreciate you being here today to give us your experiences. I'm going to ask you one by one to just introduce yourself briefly and ask us why you chose to train to be involved in assisted dying, or to be involved in assisted dying in the way that you are. So I'm going to go straight first to Dr. O'Brien. Bhawani, could you tell us why you're involved in assisted dying in Australia?
So I'm Bhawani O'Brien, and I've been a GP for 27 years and a VAD practitioner for 3. I've worked in GP jobs in Ireland, England, and Scotland, and here. And I've always had a love for palliative care aspects of it. And, we do a lot of home visits. And when I came to Australia, I lived in country Australia. So we cared for a lot of our patients palliatively in the community. And when VAD came along, or VAD came along, I became interested a year into it because, to be frank, I was very sort of wiped out in my GP job. And we had one of our lovely navigators come and talk to us, the practice, about VAD. And I thought that would be something that I would be hugely interested in. And I am absolutely passionate about it now. I do half a day of GPing, and the rest of my week is VAD practicing.
Thanks. Thank you for that. Then we come to Dr. Clare Fellingham, who's an anaesthetist. Claire, can you tell us how you got involved in this, or why you're involved in it?
Sure. Thanks very much, Jacky. So like Bhawani, I'm originally from the UK, but I've called Australia my home for 15 years. I am a consultant anaesthetist by background with a special interest in obstetrics, but I also, at the end of my anaesthetic training, did a palliative care fellowship because I've always been fascinated by those great transcendental moments of human existence. Slightly more tangentially, I'm currently in a medical executive role, but looking forward to making my way back to clinical practice next year. But it was through the opportunities in the executive role that I was able to apply for and get the role of the clinical lead for the implementation of voluntary assisted dying at the East Metropolitan Health Service, which is one of the large metropolitan health organisations in Perth in Western Australia. I led the implementation, so that basically the creation of both the service and what that would look like at the point of delivery for patients, but also the staff education and awareness campaign. And it was really through that experience that my knowledge and understanding of assisted dying and the benefits of it grew, and my investment in it as a just an extra and now legally available aspect of end-of-life choice that's available to patients. And I really just became very, very motivated to offer this care. So I did the training and have been a VAD practitioner since the very first day that VAD was legal here in Western Australia. And I can say that in 23 years of medical practice, it is by far and away the most rewarding and meaningful and life-affirming work that I have ever done.
That's really interesting. Thank you. Michael, Professor Michael Dooley, pharmacist. Would you like to tell us your involvement?
Yeah, hi everyone. Yeah, look, my background, I'm a pharmacist, and I used to work in oncology and palliative care and the Cancer Centre here in Australia, and been involved in looking after a range of initiatives around medications and such for a long time. I got our legislation was passed in 2019, and I got a phone call a little while after it was after legislation was passed to see if I would take on a role in formulating how the process would work, especially around the medications. And because at that stage we had a blank bit of paper, which was, well, legislation that said that patients could undertake voluntary assisted dying, but there was no detail about the how or the what. So I got involved and invited to help lead the detail and implementation of a protocol. And with Greg, who's also on this call tonight, took on a little bit of responsibility in coming up with the detail. As part of that, in Victoria, there was a statewide pharmacy, voluntary assisted dying pharmacy service that was established as a model of care, and I lead that. And since over the last 5 years, where we've been seeing patients, I also see patients and continue to lead that service. I got involved mainly because I wanted to make or contribute to how it could be done in a safe manner, in a way that patients and their families would be able to do it, be involved in a safe way in their homes. And that was the main driving force from my involvement. Like Claire said, it's been a very rewarding part of my clinical practice, and something that has moments of challenge, as with any practitioners, but something I'm very happy to have contributed to and been involved in implementations across our country, and have learned a lot, and hope that we've put it in place that it is a safe process that others can also learn from.
I think it's really helpful for clinicians to hear what a positive experience it is for you, actually. And then lastly, but not leastly, Dr. Greg Mewett was a GP, now involved in palliative care. Is that right, Greg? Oh, you're on mute. You're on mute.
I knew that would happen.
Sorry. Don't worry.
Hi, everyone. Yeah, I was a GP for 22 years, and the latter 15 years of that involved in palliative care. Then at a silly old age, I went back and retrained as a palliative care physician, and have been involved in specialty palliative care now for 20 years. I got involved because I was asked to be on the Victorian Voluntary Assisted Dying Implementation Task Force, which was set up by the government and the Health Department to implement the legislation from the time the legislation passed through Parliament to the time that it was to commence in June of 2019. We had a committee of 13 people, and we had subcommittees. As Michael mentioned, we served on one about the medication. Then, of course, after that all happened, I just integrated VAD into my palliative care specialty practice. I saw it as just a natural progression to offer patients what was then now a legally available option at the end of life, like a lot of other decisions that they might or might not make at the end of life, and integrated that into my practice. And I'm now semi-retired, but I now serve on the Victorian Voluntary Assisted Dying Review Board, which has oversight of the VAD process and practice in Victoria. And yeah, and totally like I find it a totally rewarding part of my practice. It just enhanced my palliative care practice.
Thank you. I think it's really interesting to hear how you've incorporated this into your greater life, as it were, in a very positive way from your point of view. I've got a couple of directed questions for each of you, and then we'll perhaps pick up some questions from our audience. I hope so. First of all, Bhawani, there's a lot of concern about motivations underlying a decision to seek an assisted death. What is it you find in your patients? Why are they looking for an assisted death?
In my 3 years of experience, these patients have been told that, you know, their prognosis, death is imminent. It's what lies very close in the future for them. Most of my patients have chosen VAD because of experiences they've had. They've seen relatives and friends die in awful ways, and you know, it takes away a lot of the good memories of that person. And I hear this all the time. I saw my grandmother die that way. I saw my auntie die in a horrible way. I don't want to have that, and I don't want my family to be left with that experience. So they know they have the choice. Choice is a big word. Choice of not having pain, shortness of breath with end stage emphysema, loss of autonomy. They don't want to be a burden on their family. They don't want to have everything done for them. They don't want the risk of losing their mental capacity, say in the case of, you know, the end stages of a brain tumor. And they choose VAD because that gives them the choice to have that peaceful, calm death in surroundings where they want to be, with people they want to be. And these people who they love are left with good memories of a good death when death is inevitable for them. So that's what I find is their motivation. And you know, they use the words choice, they use the words control an awful lot. I want control over my death. I had a 38-year-old girl, really, die of gastric cancer, and you know, she said to me, Boo, I've not had any control over this disease. I will never have a partner, I will never have a child, I will never travel, but I have the control over where I die and how I die. And that's why they do it.
And that piece is given, as you say, to everybody, not just to the patient, but to their loved ones, and of course the whole of society, who knows that if it happens to them, then that's there for them. What are your thoughts about how it has impacted the doctor-patient relationship?
Well, I just think it's nothing but positive. You know, the conversations you have with these patients, they're so fulfilling, and connection is back again. I'm, you know, certainly in Australia, and I know I've been an NHS GP. We're so hard pressed for time, and you know, certainly in Australia, it becomes a shopping list of things, and you've lost that whole connection and continuation. And we find this again with our patients in VAD. We have conversations about, not just about VAD, we have conversations about what their lives been like, what their regrets are, you know, who they'd like to see, where they'd like to be. It's so human, and talking about death, which we need to do more of. These patients are, you know, sent home being told that they're going to die, but nobody wants to talk to them about death. Palliative care, fantastic, but really, you know, when you start talking about death, that's what they want to talk about. They want that conversation. So it's the most fulfilling, like Claire said, the most fulfilling part of medicine. And I'm so grateful to have found it.
And clearly from what you're saying, the conversations you can have with patients now when assisted dying is available have changed since the conversations you could have before it was available.
Absolutely, yes. We can talk about, in our state, we are allowed to bring it into a consult as long as we talk about all the other options as well. So when they come with that, bad news to us, we talk about that bad news. We talk about what their plans are like. We can talk about palliative care. We can then talk about VAD. And we're still trying to, 3 years on, trying to get VAD out into the public because a lot of people don't know that it exists. So often for these patients, they find out from us, and it's a relief to them, that there is that option.
Okay. Finally, a big one for over here. There's a lot of naturally concern about the possibility of coercion. And I wondered what, in your experience, you had come across in terms of possible coercion and how you assess it and look for it.
Jackie, I haven't, and I don't know how many patients I've seen, probably more than 200 or 300, but my way of assessing for coercion is, we've all been doctors for a long, long time. We look at the person, we see how they communicate with us, and what the answers we get to questions. I'm a very direct person, so some stage of the consult, I will ask them that, it's really important for me to know that this is your decision and nobody else's. And I often get helpful family out of the room for that. And if I have any sense that they are being coerced, then I really, I do it at the first appointment, and then again at the final appointment, and again at the administration of the medication appointment if they're having me help them. That I'm very clear about that, and it's communication and connection. You can't do this job without that, and we're all doctors and we should be able to do that. The feeling you get from a person is very important.
Okay, that's helpful. Have you come across the reverse, where families have tried to discourage their loved ones from having this?
Absolutely, that's the more common scenario, and I've had families say to me, "We feel you might be coercing my father." Yeah. And we've had a talk about it, and that's when we have a group discussion about it, and the person involved gets his or her say, and we do have to emphasize a lot to the family that, it's an interesting journey, VAD, because often we come into a family where family members are quite surprised and shocked that their loved one has chosen this, and it's just because they don't know a lot about it, and they see the relief that their loved one, feels as we get through the assessment. That's the other big word I hear all the time. When we get to the final assessment and I go away to write the prescription, the patient will say, "I'm so relieved that this is in my back pocket," because as we know, 30% of people don't end up using it. And that makes their loved ones happy because the person then is able to live whatever life is ahead of them, knowing that they won't suffer. And that has changed the minds of so many family members and loved ones. I've had so much feedback afterwards saying, for a start, that they never realized it was so peaceful and painless and calm, and that they had seen their loved ones so happy in the last few weeks of their lives.
That's a really important point, isn't it? That people can get on with living what's left to them rather than fearing the death that's waiting for them. Well, thank you for that. I'm going to move on to Clare now, if I may. There's been a lot of discussion over here about determining prognosis and how much that matters and whether it's a challenge. I wonder whether you could give us your thoughts about determining prognosis.
Certainly, and it is, prognosis and capacity are the two, probably the two biggest challenges that we face on a daily basis in relation to voluntary assisted dying, but that doesn't mean that they're insurmountable. I think prognosis is important to think about in a broader sense in terms of the patient cohort that we're talking about here. Much like your laws and many of the laws that exist in the world, we're talking about only offering an assisted dying pathway to someone who already has a terminal illness. And we know that the vast majority of patients, so about 65–70% of those, will have a cancer-based diagnosis. Now, cancer obviously has many different modalities of treatment. People often follow a, treatment, remission, relapse, further treatment. There are many different ways to treat somebody with cancer, but oncologists will agree that eventually people will come to the end of that journey, whether that's cure or whether that's that they're going to die. And when an oncologist is able to say to you, I really don't have anything left to offer you, then the question of prognosis is largely taken care of, because it's very rare that that will happen and somebody's got 6 months left to live. So that's already 65–70% of our patients. And the same applies with hematological malignancies and whether or not you're transfusion dependent. The other large proportion of patients, 10 to 15%, are those with neurodegenerative diagnoses, for which, of course, motor neuron disease is the archetypal condition, and amongst whom both patients and their relatives have been the most vocal drivers of these laws across the world, because motor neuron disease has no known cure, very few treatments that even forestall the relentless progress of it, and follows a relatively predictable clinical course dependent on the variant that you have. So already in 80 to 85% of the patient cohort that we're talking about voluntary assisted dying being applicable for, we have usually really quite clear prognostic grounds for determining their eligibility. Now, that doesn't mean that in 10 to 15% of patients that it's not challenging sometimes, and sometimes it is. Sometimes we need to reach out to our specialty colleagues, and I'm really proud of the collaborative relationships that we have developed with many of the specialists that work in our network and patients' own general practitioners, who of course know their patients extremely well, who are able to work with us and help us with prognosis. Sometimes it involves further investigations and sometimes further tests to try and determine eligibility. And sometimes we actually find ourselves at the point where we perhaps can't determine exactly prognosis. But then one of the wonderful things that I rely on is the benefit of time. In the same way that somebody who's just been diagnosed with motor neuron disease, I wouldn't find them eligible, and then neurologists would be unlikely to support their prognosis because you need to see how they progress over time. I find that two words, time and yet, are really, really important in determining prognosis, because we don't have to make this rash, quick decision, yes, no, right there, then, are we going to operate, we're not. I walk the journey with patients and I say to them, look, I'm really sorry, I can't fit you into that time frame right now, and I'm strongly bound by the letter of the law here, but I'm not going to abandon you. I'm going to walk with you on this journey. We're gonna do some more things together, and I will, not yet, but if you want to get there, we'll get there. And often that is satisfying enough for patients. I think the other really important thing to think about prognosis as well is that we're not, if you look at the studies, and a lot of people who claim that prognosis is impossible in assisted dying will cite studies that say doctors are terrible at anyway, even oncologists, even people who are supposed to be good at prognosis, palliative care specialists, everybody else. Yes, we don't tend to be brilliant at time frame prognoses, but what we tend to be in the context of not being good at it is overly optimistic. In most of the studies that say doctors are crap at prognosis, it's because 2/3 of the time we're hedging our bets or we're trying to be hopeful, and actually the reality is that people are much closer to the end of their death. So I think in summary, it's less of an issue than I think people think it will be. And in those cases where it is an issue, of course, we treat that with incredible professional respect and the necessity to not find people, you don't just fudge it or cut the corners,
Without putting words in your mouth, do you think it's fair to say that people aren't going to take the medication until they come to the end of the road, as it were? They're not given the diagnosis and then they take the medication. And therefore, if they live another couple of months beyond what was predicted, then that's another couple of months they have with peace of mind. Is that fair to say?
Well, I think it's really fascinating to sort of think about this. And for a lot of people, it would be surprising what I'm about to say, but that can actually be quite life affirming. The journey of an assisted dying death can actually offer people significantly more life, because often people are scared. Of course they are. They're fearful. They're perhaps not getting the full answers that they want, or maybe they don't have the rapport with the doctors that are looking after them that they feel they can even ask. You know, it's really difficult to have these conversations about people's natural end of their life approaching. Whereas that's our bread and butter. That's what we do in the world of assisted dying, and we have to, you know, to make sure somebody understands what they're asking for, to make sure somebody's not being coerced, to make sure somebody really does understand that if you take this medication, it could cause your death. But in having those conversations, you dispel so much fear and you relieve so much anxiety that quite often patients are like, no, this is what I want to get to the end. And my personal preferred practice is to get people to the end of the journey. I say to them, I would love to get you to the point where the script is there, provided obviously they fulfill the eligibility criteria. I'm not talking about people for whom we're still trying to nut out prognosis, but I get people to the point of the prescription and I just say to them, and let's just pause there, because at that point, you know that you have this available to you. The minute that that you decide that you want it, you can have it. And that breathing space is an extraordinary space that actually allows people to just get back to the business of living. We've mentioned it already before, but it's hugely anxiolytic, and it's very, very, it's a positive and life-affirming benefit of VAD.
That's really helpful. Thank you. I'm going to move on to Professor Michael Dooley now. Michael, you told me some extremely interesting things when I met you recently in London, and I would like other people to hear them. Can you tell us how the substance was decided on, and about your experience in time to death, time to fall asleep, time to death, and complications as a result, and why it would be really helpful to compare what goes on in Australia with what we've heard goes on in Oregon, which is different for reasons that you can explain to us.
Yeah, thanks, Jackie. So, I mean, I think when we looked at it back in 2019, it's really again and having a look to see what had been used, what the approaches have been overseas, because Victoria was the first place in Australia. And the model in Australia we're talking about self-administration of an oral substance. So, and the only places that have been really doing that have been the Netherlands, and also some experience in the US, where some of the other countries that have been using assisted dying were using it in an injectable form. So I had to come up with an idea or a way for it for self-administration of an oral substance. And the key bit, firstly, was to come up with some principles of what we actually wanted it to be. And the first thing we wanted it to be was something that was safe, something that we knew would work, and something that was able to be self-administered by a patient, by themselves, in a setting where it could be a range of diseases that may have brought them to having to make that decision, whether that be a cancer or a neurological condition. Or so it had to be something that was safe. It had to be something that was going to be able to be self-administered, and something that was available. And so when you looked at the evidence internationally, the best medication or the best drug was pentobarbital. And whereas the experience in other countries, you know, Oregon is often mentioned, they didn't have access to that medication. And so it come up with a whole range of different cocktails that we considered weren't appropriate. So in Victoria, we chose pentobarbital at a reasonably big dose, but from the experience of the Netherlands. And then we had to decide how we're going to make that available in a manner that was going to be safe for patients to self-administer. And 3/4 of our patients, we knew the majority of our patients would be self-administering in the home. Some would be doing it in hospital, but the large proportion of patients would be doing it in their home unsupervised, whereas the model that you're considering has got another layer of supports for those patients. So it had to be safe, it had to work, it had to be able to be self-administered in the home, unsupervised by a healthcare practitioner. Came up and settled on pentobarbital at 15-gram dose, And then we decided that we needed to make that in a formulation that was going to be easy to administer. You couldn't get patients to take 100 capsules. So therefore, it was decided that we would use a powder that would be mixed in a small volume of liquid, small enough that patients could take it because it tastes terrible. And we wanted to be something that was, even though it was unpalatable, would be of sufficient volume that could be self-administered, especially in the circumstances where a lot of the patients were obviously with advanced disease, which they may not have been able to take a large volume of liquid. So we decided on a powder that was mixed up with a 30 mils worth of liquid, and the patients were able to self-administer. The experience of Victoria so far, and we've seen just over 2,000 patients, and across Australia, probably close to 1,000 more than that, probably well over 3,000 patients who have administered the medication. Every patient that has administered the medication has died as a result. No patient has woken up. 75% of our patients have administered in the home, and the large majority of those unsupervised by anyone with a health background. We know the medication tastes terrible. Patients go to sleep within minutes, and the large majority of patients, 80% of patients, will die within 60 minutes. There's a small number that will die between an hour and 2 hours, and a small number that will go longer than 2 hours. But all patients who take the medication end up dying. We get feedback from the patients, not from the patients, but their families and carers who have been with them. And we have hundreds and hundreds of these feedbacks that have been provided for those who have been there and witnessed and been involved in the deaths and the taking of it. And when you plug all the words in of the narrative that they write, the most common word that's in the narrative is the word peaceful. Patients who take the medication taste terrible, no denying that, but they're asleep. They fall asleep very, very quickly and they die. And for those that are witnessing it, the most common word that they use is peaceful. So we know that the medication works. We've had the experience in Victoria and across our, the other states have also used exactly the same medication. Each time, each state has decided to implement. They have done exactly the same as what Victoria did, reviewed the literature and the experience elsewhere, and came up with the same approach. And when we did our 5-year review just recently in Victoria, and a review of everything that happened, the recommendations were to change nothing associated with the medication that we've been using.
That's really extremely helpful to understand that the cocktail of drugs that we hear about is only there because the Americans can't get hold of the first line medication that you could and we could if legislation passes here. And I remember you saying to me when we met that you had not heard of any complications apart from the unpleasant taste, and that beforehand the patients are tested to see if they can ingest this amount of liquid in the time. That's right, isn't it?
Yeah, one of the things we do and the patients have is they're given a dummy dose of the same volume of liquid and have to demonstrate that they're able to swallow that. We need them to swallow it pretty quickly, in less than a minute because they fall asleep fairly quickly. And that's part of the process. And we've been able to show that by putting those safeguards in place, by having the right medication accessible, and by doing these checks and balances, that it can be administered safely. And it's been done from patients who are 18, patients who are 100, and across a whole spectrum of diseases, in homes, in hospitals, in caravans, in a whole range of different settings, with people doing it by themselves alone and those in very supported environments, that it works safely. And patients will fall asleep. They fall asleep, they are unconscious, and then they die. And the usual processes of death that people may see in anyone dying also happens.
That's really helpful. Thank you. I'm going to move on to Greg now because you also work in palliative care now. I'm interested to know whether you've seen a change in opinion amongst your palliative care colleagues towards what we call assisted dying. Has there been a shift since the law came in?
Yes, I mean, traditionally, the palliative care hierarchy, if you like, have been adamantly opposed, as I'm sure there are many vocal opponents in the upper echelons of palliative care in the UK have been very vocal about opposing VAD. But what I've seen since legislation has been introduced, and as I said, I now work not just in Victoria, I work in other states, New South Wales, Queensland, as well, and it's quite remarkable how there is now almost an integration acceptance that this is a choice that a minority of our palliative care patients will make or wish to be assessed for. And I also know anecdotally from myself and other colleagues that the younger generation of palliative care trainees, as they're coming through their training, are just taking it in their stride and as part of a normal part of their work, as I said earlier, a part of end of life choices that people will make and are aware and are prepared to have the discussions. And many of my junior doctors that I've been involved in training in this last 4 or 5 years have gone on to do their VAD training and are now VAD providers, assessors and providers. So yeah, I think there is a changing of the guard. There'll always be that strong resistance at some areas, but really it doesn't stand up to logical scrutiny in my view. I think it's a historical view, and I think it'll change over time as people see this as part of, this is a societal change in people's values about their death and dying.
And just to confirm clearly that doctors who don't want to be involved aren't involved.
Absolutely. I mean, there are ethically defensible views about VAD on both sides of the coin, if you like, and I believe I have an ethically defensible view about my involvement, and I also respect the ethical and moral view of people who oppose it. What I don't, and we have had a few instances in Australia of people who've been obstructive in their palliative care role, and that is now diminishing over time, because ethically it's, in my view, improper to obstruct access to a legally available end-of-life care choice. But generally, yes, absolutely, people have every right not to be involved and shouldn't be, and are not in Australia, forced to be involved. Even in Victoria, we don't even have a requirement that doctors have to provide a referral or provide information. That's different in some of the other states of Australia, fortunately.
Okay, thanks. And could you say, do you think the advent of assisted dying in Australia has helped or hindered palliative care in general?
Yes, very good question, and that comes up all the time. And it's, I have to say, that there's no evidence. In fact, if anything, it's enhanced palliative care. I mean, governments have been very careful to put more money into palliative care alongside funding for VAD services. And I know this argument's brought up around the world. It's been refuted, and with some quite strong arguments in a recent paper by Ben Colburn, who's a medical philosopher at Glasgow University, about the palliative care-based arguments against VAD, and it really doesn't stand up to scrutiny anywhere in the world. In fact, Palliative Care Australia commissioned a report a few years back now, which looked around the world at palliative care services in jurisdictions where VAD had been introduced, and found absolutely no evidence of any impairment or change. In fact, often enhancement of the availability of palliative care services. So it's a furphy, a non sequitur.
Yeah, so that's really important to emphasize, I think, for people listening, is that palliative care certainly doesn't lose out when assisted dying comes in. And my impression is it actually focuses on end-of-life care, and which has not been adequate in many places until now, and helps to improve that. Just one more question for you, and then we need to move on to, because we've got some questions here. Do you think, could you just comment on perhaps a bereavement experience before and after palliative care for people, who love families of people who choose assisted dying?
Yeah, look, I think it's an area that still requires more research, but certainly some of the initial reports, particularly from the USA, and more recently in Canada, look at the bereavement follow-up. There's no apparent increased incidence of complicated bereavement in patients after a VAD death. Now, that's not to say there aren't issues around bereavement. Of course there are. We know these patients, A, these patients don't want to die, but they're dying anyway, and B, their loved ones don't want them to die. So it's going to be sad whichever way you shake it up and shake it down, and there's going to be bereavement. There'll often be issues around family conflict. So where a family is in conflict over, I don't agree with my mother having this or my brother having this, but that's the same in any palliative care work prior to VAD. There are patients who are more prone, and families more prone to complicated bereavement. And in fact, intuitively, when you think about it, and what Boo referred to before about people who feed back their experience of their VAD death, of the peaceful death of their loved one, and the thankfulness they have of being able to respect that person's choice. I think that actually, in many ways, enhances their bereavement experience, albeit there will be, exceptions. And I think more research is going on into bereavement with VAD, but it's certainly nothing to be feared. There's nothing spooky about VAD when it comes to bereavement.
Okay, thank you. I'm going. Thank you for all of that. That was all lots of helpful points there. So we're getting some questions in. How do you respond to the common accusation that VAD somehow devalues lives? What do you think law change says about your society's values? Anybody like to take that one on? Greg?
Oh, just because I've got my microphone still on.
Yeah, go on.
Whole position here. The VAD devalues lives.
That's what we're hearing from some areas.
I guess my point of view, really, from a patient-centered care perspective of a palliative care physician, is it's the patient who has to put the value on their own life. It's the patient who determines their own level of dignity. It's the patient who determines their own quality of life. It's not us who determine that. And that increasingly patients wish to have some say in that end of life stage, as they have a say in other aspects of their life. So I don't think it devalues life. It allows people to make a positive choice about how they end their life when they're already terminally ill.
Okay, anybody else like to say something about that? No, okay. No hands up. Beyond obstructing...
I can jump in there a bit more if you want an extra bit of answer there, if you like.
Yes, please do. Yeah, but if you just wave at me, if you want to add, go on, Claire.
No worries. I mean, I completely agree with everything Greg said, and I actually find it quite a perplexing question, because the whole purpose of VAD is that it's absolutely life-affirming. It's life-affirming because it acknowledges the inevitability of an individual human being's death. It's not a nebulous context. It's not some doctor-patient relationship. It's a dying person who is given the ability to have some agency and some control over a disease process that has, up until that point, often been utterly consuming and completely beyond their control. And the quality of the life that a person is able to live when they are given the absolute certainty that they don't have to suffer, that their wishes will be respected, and most importantly, that they will be heard. People, it's such an unfair and inequitable power balance, the doctor-patient relationship. There is so much doing to others that doctors do, and often in the course of a treatment of a disease process, not willingly, I don't think, but subconsciously, we don't often always just engage with our patients about that journey and talk to them about journey. VAD is the ultimate leveler. It is a doctor putting themselves in a position of discomfort, because we have to explore suffering. We have to explore really deep existential and medical reasons for wanting to go ahead with assisted dying. And we absolutely level that playing field and give a person back their life. And so it is ultimately the greatest expression, not just of patient-centered care, which I think everyone can kind of get their head around and we all understand is really important in the days of, you know, autonomous self-determination. It's not just patient-centered care, it's patient-directed care. We give them the opportunity in the same way that we do, you know, would you like an operation or not? Do you want this line of chemo or not? We give them the choice to make for their own life. And so it is life affirming. It is not, because, you know, it's an inevitable death and it's theirs to have back.
Bhawani.
Really quickly, I totally agree with what Greg and Claire have said, but just to add, you know, there's two certainties in all our lives. We will be born and we will die, and we have so much planning and choice and control over how we give birth, where we give birth. It's time we started having those choices and control over our deaths, when death is imminent, when death is, you know, a certainty in these cases within 6 months. So, you know, that's it. We just need to talk more about death. We're terrible at talking about death as medics.
So you're really saying that you see, there's been questions about what it does to the doctor-patient relationship, but what you're saying is that it allows you to have conversations with people that are much deeper and more useful conversations than went on beforehand.
Absolutely.
Yes, thank you. There's a practical question here. I'm interested in the training to become registered to provide VAD. Do you have any thoughts or reflections on this? What does it look like? Is it mostly GPs or hospital doctors who undertake it? Who would like to say something about that? Claire, as a hospital doctor, go on.
Yeah, I'm happy to jump in there. I think it does depend ultimately on the type of legislation that is passed in the UK, and whether or not, you know, the sort of preponderance will be towards hospital medicine or general practice. I think the general thought here was that the vast majority of cases of voluntary assisted dying would be within the community and handled by a patient's own GP. And I think if that were the reality, that would be fantastic, because patients' own GPs tend to know them better than anybody else and can really help inform those conversations about coercion, capacity, eligibility from a prognostic point of view. But the reality is that actually it's about 50-50 here, general practitioners versus all other doctors. And the training is, or the criteria for training will be something that once the law is passed, the implementation phase will tease out. Here in Australia, in Western Australia, you have to be a specialist in your own field of practice. So I'm an anaesthetist. You have to have at least, I think between us and Victoria, it's between 1 and 5 years of specialist practice at a 1 FTE equivalent under your belt. So you really have to be quite a senior doctor before you can even begin the training. And then you do a very specialised training package that's been developed for us by the Queensland University of Technology and the Australian Health Law Institute, which has a fairly rigorous exam with a mandatory 95% pass rate or something at the end. It's quite hard, to be honest, to become a voluntary assisted dying practitioner, to make sure that people don't just fall into it because they don't have any other options, or they get into it for some other weird reason. But what happens as a result of that is that it's a fairly self-selecting group of people, and by far and away some of the most collegiate and wonderfully supportive professional relationships that I've developed throughout my working life are also with other people who offer all the different aspects of voluntary assisted dying care, not just the doctors, but we've got wonderful nurses, pharmacists, social workers, and it really is a very, very collegiate community full of like-minded individuals who are really passionate about offering patients choice and compassionate care at the end of life.
I have been very impressed. Yes, I come to you, Bhawani. I've been very impressed by all of you talking about the relationships that arise as a result of this, with people working together across specialties and across, you know, hospitals and GP practices to come together to do the best thing for the patient. Bhawani, do you want to answer that? And I'm going to try and fit in 2 more questions before the end.
Okay, I'll try and be quick. But as a GP doing it, I trained I did my VAD training during COVID, so it was the 7-hour online training, which I understand is still there. But recently, what the health department has done is they've funded workshops as well to help the health professionals who are interested in doing this job. So the workshops are held all around the state, where we have practitioners giving their, talks on how the job goes. You can go along and have a practice kit, look at how the medications work. So these workshops are also, subsidized so that people can attend them, because I work in a huge state and there's a lot of travel involved. So, the support as well is there. We have community of practice meetings. That means that we can talk about things, because I understand one of the issues is the fear of how this will affect medical practitioners doing this job.
Yes.
And I can say, after being a GP, and I've been a breast physician, and I'm now a VAD practitioner, it's the most support I've ever had.
That's really helpful.
Yeah.
That's really helpful. And if presumably if people find it all too much, they just opt out. But it sounds as you say, so it's one of the most supported areas. A question now for Michael or Greg, or both of you. Beyond obstructing access, which we heard about from Greg, has there been any pushback since the legalisation of VAD in Australia? And of people who had concerns now, is there any campaign going to repeal the laws? Michael, have you got any thoughts on that?
Yeah. Look, I think things have changed substantially. And as Greg's mentioned around palliative care, I mean, I think initially it was sort of like secret business that sort of happened and no one really knew about it, especially in Victoria, where we were first to implement in that country. I think that's changed substantially. And we see this now as it's much more an accepted choice for patients to have access to. And as a consequence of that, we're seeing that, especially in the early career practitioners, are just seeing that as something that's normal. In the past, we visit patients anywhere in our state, hospitals, aged care services, everywhere. And sometimes in the past, we had to sort of go through the back door, not no one know that we were coming or any of that. Sometimes had pushback from heads of units where they didn't want access on their wards. And that put a lot of people in challenging positions. That's changed substantially. It probably took a couple of years of the processes to be worked through for people to then have patients that they'd been involved in, to have seen how the processes work, to families to be able to share the journeys they'd been on and how things had gone well. So I think it's changed markedly, especially I think medically, but across all the health professions, going from being something that was sort of not really known about, or people have been very conservative about, to after a couple of years really being much more established as a routine choice, not a routine choice as in it more being an established choice that patients should have access to. And it has become, more mainstream, if we want to use that word. That took some time, but it's changed substantially over that period. And I think probably Greg may want to comment, or already has commented around how that's changed significantly in a lot of palliative care services that we've seen.
Thanks. Yeah. So Greg, if you want to comment and say, has there been any attempt to repeal your laws over there?
Oh, there's always murmurings in the background about repealing laws, and there's certainly some anxiety about some state governments, but no one's actually shown any appetite. I mean, the people have really spoken through their parliaments in 6 states and 1 territory of Australia. These same arguments that are being thrashed out and discussed in both Scotland and Ireland, in Scotland and England and Wales, have been thrashed out in every jurisdiction in Australia. And so they should have been, I guess. Everyone has to have their say. But in the end, the government, the parliaments have decided to pass the legislation. This is the will of the people. That doesn't mean everyone want access to it when the time comes, but they wish to have that as available as a choice. And I don't see that being wound back at any stage. I think, as Michael said, it not routinization, but it's an acceptance that this is how a modern society wants wants to have in terms of options around end of life.
Okay, I want to give everybody a chance to sum up, but there's just one question that perhaps we could have one sentence answer. What research is being done to understand patient experiences, and how does this compare to other end-of-life practices? I'm not sure, but is there any research going on at the moment? Greg first.
Well, I think Claire mentioned, I mean, the Centre of Health Research at Queensland University of Technology, Professors Ben White and Lindy Wilmot, so two of the foremost researchers in assisted dying in the world. And their team, their very, very strong team, collaborate with other teams around the world and have published numerous articles about the patient experience, the doctor experience, the pros and cons of various amendments to the laws that have been possibly mooted. So yes, there's a lot of research going on. Claire?
Claire?
Yeah, just to echo that, Professor Ben White, Professor Lindy Wilmot, write those names down and look them up. All of their work is publicly available, as is, I'd like to add to Greg's statement, the vast majority of all of the work that's been done in every state in Australia to debunk the oppositional arguments that are continuing to be raised in this European English debate, you can find the Joint Select Committee report on end-of-life choices from Western Australia called My Life, My Choice. You can find the Victorian Parliamentary Inquiry. They're all publicly available documents, as are the Voluntary Assisted Dying Board reports, which clearly demonstrate incredibly rigid and robust oversight of the laws in operation, and they're all publicly available.
Okay, that's really helpful too. Thank you for people who want to follow that up. Right, we've got just under 5 minutes left, so I'm going to ask each of you to what message would you give to clinicians in this country and to the people who are going to vote on Friday that would make them think we want to follow in your footsteps? And we'll start with Bhawani, if we'll go around the same order.
Jackie, I'd say, just what I've said before during the talk as well, is that, death is a certainty for us all, and palliative care is fantastic, but it doesn't always ease the suffering for some patients. And VAD is a choice for some of these patients, should they choose it when death is very close, to have that painless, peaceful death. And that leaves their loved ones having a better memory of the patient dying, and it has had a profound impact on my life as well. I live a life of purpose now because I do this every day, and I spend a lot of time finding joy in life. I was much more affected by the terrible deaths that I've seen in my 30-year career. These are magical moments, and it's just a priceless gift for us and the patient.
Okay, thank you. Claire?
Thank you. I think my message is simple. Voluntary assisted dying is challenging and confronting at the stage that you're at, and it's very easy to feel overwhelmed. But please, please remember, broadly, there are two models. Assisted dying that's much more permissive, like the Belgian and the Dutch and the Canadian models, or assisted dying that only applies to people who are terminally ill. And that's what we have here in Australia, and that's what you're thinking of contemplating in the UK. And what that means is you're not offering people a choice between living and dying, you're offering people a choice between dying and dying. And all we're seeking, or all people are seeking, is the choice to have some agency and some control over that. It is an extraordinary gift to offer someone peace and comfort and a dignified death of their choosing. So please remember that.
Yes, thank you. Really important. Michael, any thoughts that you'd like to send to parliamentarians and doctors over here?
Patients just deserve the right to choose. And what we have to do as practitioners is to be able to, when they make that decision, support them in a compassionate way to do that safely. And that's the experience we've had in Australia, being able to provide safe and compassionate care, so that if they make that choice, it can be done safely, and therefore, from the UK perspective, learn from that experience, put the safeguards in place, and give patients the choice.
Okay, thank you. And finally, Greg, any messages you'd like to send?
Sure. Firstly, to clinicians, this is patient-centred care par excellence, and it has enhanced, as I said, my palliative care career. For lawmakers and now serving on a VAD review board, assisted dying legislation can operate safely. It does operate safely, and is in line with, as I said, modern society's expectations about control and some input into how they end their lives. It is nothing to be afraid of. It can work, and it does work.
Thank you. I think it's, it is working. It's working where you are, and you're an absolute testament to that today. It's been really, really helpful to me listening to you all. I thank you all for coming. I've certainly met Michael in person. I've met some of you online before. It's really good to see you again. Thank you, the people who attended the webinar. We're going to be putting out some clips of it to MPs and on social media. And I think we've got some great clips we can take from that. To the people who attended today, email your MP if you feel strongly about this. It's not too late now. To the doctors, if you don't belong to healthcare professionals for assisted dying, do sign up with us. You'll get news, encouraged to write letters, and it doesn't cost anything. And what we really need in this country, and I'm sure they are out there, there's no question in my mind that we have clinicians like you guys who want to do this, who just want to be enabled to do it, trained to do it, show compassion, and who would find a great depth of meaning in it, as we've heard from you today, that to give people that choice at the end of life allows them to live until they die. As I've said before, and I've been doing public speaking, no more people will die, but fewer people will suffer, and they'll have that peace of mind. So thanks to everybody, and we hope something good happens on Friday. Keep your fingers crossed for us down there. All right. Okay, thanks very much.
All the best. Thank you.
Okay, bye.
Thank you.
Bye.
Okay.